From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
My name is Dr. Gregory Kerfman, and I'm the executive editor of JAMA. I have the privilege today of speaking with Dr. Margaret Redfield and Dr. Barry Borlaug, who are internationally recognized authorities in heart failure in the Department of Cardiovascular Disease and the Division of Circulatory Failure at Mayo Clinic. Together, Drs. Redfield and Borlaug wrote a review article published in the March 14th, 2023 issue of JAMA titled Heart Failure with Preserved Ejection Fraction, a Review. And we will be discussing that article with them in this JAMA Clinical Reviews podcast. Thank you very much for joining us, Dr. Redfield and Dr. Borlaug.
Thank you for having us.
It's a pleasure to be here.
Dr. Redfield, to get us started, could you please give our listeners a definition of heart failure with preserved ejection fraction and distinguish it from heart failure with reduced ejection fraction?
I think we all think we know what heart failure is, but in 2021, there was this international consensus document published that gave a universal definition of heart failure. So we'll start with the what is heart failure first, and then talk about what is heart failure with preserved EF or HFpEF. And in this universal definition of heart failure, they stipulated that, of course, you have to have symptoms and signs of heart failure. And really the big one here, the most important, is shortness of breath or dyspnea. And this can be at rest or with lying back, orthopnea, or wake you up at night, paroxysmal nocturnal dyspnea, or it can occur just with exertion. And this is often, but not always, associated with other symptoms or signs like fatigue or edema or ascites. But these signs and symptoms are nonspecific, as we know. And so the universal definition stipulates that there also must be demonstrable cardiac structural or functional abnormalities. And that's usually demonstrated at echo or a heart catheterization, showing evidence of systolic or diastolic dysfunction. And then the definition further stipulates that there has to be evidence of congestion, and it doesn't have to be apparent at rest. It can be just apparent with exercise. And that can be shown on physical exam, elevated neck veins, chest radiography can show pulmonary edema or pulmonary venous hypertension, natriuretic peptide assays can be elevated, or a resting or exercise echo or resting or exercise right heart catheterization. So you really have to have all that for the definition of heart failure. And if you meet that, then there are subtypes that depend on what the ejection fraction is at the time of the diagnosis. And so heart failure with preserved EF or HFpEF stipulates that the ejection fraction has to be greater than or equal to 50%. And then if the ejection fraction is less than or equal to 40%, we call that heart failure with reduced ejection fraction. And then there's this sort of middle child where the EF is 41 to 49%, and we call that heart failure with mildly reduced EF. And I think just one really critical point to emphasize is that this refers to the ejection fraction at the time of diagnosis. It's very common that patients who have had heart failure with reduced EF, 20% at the time of diagnosis, they get put on therapy, and their ejection fraction can go back to completely normal. But we always consider them to have HFrEF. And we always continue their HFrEF therapy because if we stop it, they are likely to drop their EF again. So it's the EF at diagnosis.
Now, Dr. Borlaug, I wonder if you could give us an idea of the scope of the problem, the heart failure problem in general, and more specifically, the number of people affected in the U.S. with heart failure with preserved ejection fraction.
Thanks, Dr. Kerfman. This is an important issue, and the most contemporary estimates hold that between 5 and 6 million Americans have heart failure, and at least 64 million people around the world have heart failure. The best estimate of proportionality is that about half of these patients have heart failure with preserved ejection fraction. But that proportion of the entire heart failure pie has been growing over the last 20 or 30 years as treatments for diseases that lead to HFrEF, like coronary disease, have gotten much better. And as we have become older and heavier, secular changes in the demographics of Western societies, where there's a shift leading to risk factors that are more typical of heart failure with preserved ejection fraction. But a lot of us in the field think that these numbers are really underestimates because it can be very challenging to make the diagnosis of HFpEF. Some studies from population studies like ERIC have shown that a number of people out in the community with significant symptoms of breathlessness but no clinical diagnosis of HFpEF based on their risk for new heart failure events and based on their risk probability scores using a score called the HFpEF score is so high that maybe a lot of these people have undiagnosed HFpEF and they're just being sort of falsely reassured that they have shortness of breath due to something else. It's difficult because in HFrEF, you can simply perform an echocardiogram and you see the ejection fraction is low, but in HFpEF, the ejection fraction is normal, and that's the same thing you see, obviously, with other causes of dyspnea, like lung disease or deconditioning.
Dr. Redfield, Dr. Borlaug referred to risk factors for heart failure with preserved ejection fraction, and I wonder if you could summarize those for our listeners.
Yes, Barry mentioned a couple of the really important ones. Kind of the top four are a history of hypertension. Obesity is a huge, huge risk factor for HFpEF. Older age and the presence of atrial fibrillation. Patients with atrial fibrillation very commonly have HFpEF, especially if you cath them. And patients with HFpEF, about 60% or more will either have AFib at the time they're diagnosed with HFpEF, have it concomitantly with that diagnosis, or develop it in the future. So it's a very strong risk factor or associated condition. Also, diabetes and dyslipidemia are additional risk factors. One thing I think it might be a little bit important to elaborate on is gender. Early on, HFpEF was considered a diagnosis of women, small elderly women that had HFpEF. And most observational studies currently still show this female predominance. About 65% of any cross-sectional study of prevalent HFpEF, about 65% will be women. And part of that is age. Women live longer than men, and some people don't get HFpEF until they're older. We're seeing, unfortunately, more and more of it in younger patients. And so age being a risk factor, along with being women, may be more likely to get it. However, in some studies that looked at incident HFpEF, if you controlled for age and other risk factors, female sex was not significantly associated with HFpEF. However, in those same studies, if you control for age and other risk factors, women are much less likely than men to get HFrEF. So I think, again, the big things are hypertension, obesity, older age, and atrial fibrillation.
Now, Dr. Borlaug, in making the diagnosis of heart failure with preserved ejection fraction, cardiac catheterization may be performed. And I wonder if you could briefly summarize the typical hemodynamic findings at cardiac cath, and also briefly mention something about the biomarkers, BNP and NT-proBNP, in heart failure with preserved ejection fraction.
Absolutely. Heart failure is a clinical expression, breathlessness, fatigue on activity, like Maggie mentioned earlier, but it needs to be associated with a failure of the heart to do its job as a pump, which may be to inadequate ejection of blood or the requirement for high filling pressures in order to maintain cardiovascular homeostasis and pump blood out to the body. And that's the abnormality that's more consistently seen in patients with HFpEF, an elevation in cardiac filling pressures, which can be measured by the left ventricular end diastolic pressure, the left atrial pressure, or most commonly a surrogate that we use by right heart catheterization of the left atrial pressure, which is the pulmonary artery wedge pressure. So when we've looked, the best evidence we have from consecutive series of patients is about 2/3 of patients with HFpEF have an elevation in their pulmonary artery wedge pressure or LV filling pressure at rest. And about a third of them have a normal left atrial pressure at rest, but this becomes pathologically elevated during the stress of exercise, which, of course, is when most patients with HFpEF really become highly symptomatic. It's also not uncommon for patients with heart failure and preserved ejection fraction to have elevation in right atrial pressure. And this can be seen on physical examination through jugular venous distension. And then we also see a secondary elevation in pulmonary artery pressure. This can be due to passive transmission of high left atrial pressure downstream back into the pulmonary arteries, or a number of patients also develop an increase in the resistance of the lung blood vessels, the pulmonary vascular resistance, which also drives up the pulmonary artery pressure. So people with more severe hemodynamic abnormalities have worse outcomes, but a number of patients, probably about a third to 40%, have pretty normal looking hemodynamics at rest. Now, the biomarkers NT-proBNP and BNP, or brain type natriuretic peptide, are markers of heart failure and congestion. They are released in the heart due to increases in wall stress. So as pressure gets high, as the chamber dilates, BNP is released, the cleavage product NT-proBNP as well. And that's why these have been used as tests to evaluate for possible heart failure for many years. These work well in heart failure with reduced ejection fraction, but we have seen consistently over the last decade that a large number of patients with HFpEF have normal levels of BNP and NT-proBNP, maybe 30 to 40% of patients. And these patients tend to be more obese. We know that obesity has an inverse relationship with natriuretic peptide concentrations in the blood. And a lot of them have this signature of normal left atrial pressures at rest that only become elevated during exercise. But even as these values are normal, we have seen that these patients do have increased risk of heart failure events, and they have similarly impaired quality of life and patient-reported health status. It is a big problem, and it really confounds diagnosis. To put it bluntly, you simply can't use normal NT-proBNP and BNP levels to rule out HFpEF because they are not effective as a rule-out test.
Back to you, Dr. Redfield. Heart failure with preserved ejection fraction has been a puzzling disorder for a long time. How do you get heart failure with a normal or near normal left ventricular ejection fraction? And recently, it appears that heart failure with preserved ejection fraction is a multi-system disorder, and that different organ systems may be involved, and that the pathophysiology seems to be complex. And I wonder if you could give us a brief summary of some of the key mechanisms that appear to be involved in this disorder.
Yes, it is important for everyone to understand this concept because, in large part, the paucity of effective therapies for HFpEF are directly related to the fact that we don't know for sure what the pathophysiology is. Initially, because so many patients with HFpEF have hypertension, it was thought the hypertensive heart disease theory of HFpEF pathophysiology. And we know that treating hypertension prevents heart failure of either kind. So there was good rationale to think that HFpEF just might be a form of hypertensive heart disease. But on closer examination, really not all patients with HFpEF have a history of poorly controlled hypertension, and they don't all have evidence of LVH, actually less than 50%. And even other studies have actually looked at the heart and showed that they don't all have fibrosis. So this is probably a very important subset of HFpEF, but this theory likely doesn't explain all of HFpEF. So then the next theory is kind of the inflammation theory. And this arose because we know that patients with HFpEF are older and they have a lot of different pro-inflammatory comorbidities like obesity, we've talked about diabetes, lung disease, hypertension itself, kidney disease. And these inflammatory comorbidities can cause microvascular inflammation, which can lead to impaired myocardial perfusion due to this microvascular inflammation with dysfunction and actual destruction of the microvasculature and microfibrosis and diastolic dysfunction. This inflammation leads to oxidative stress, which can impair nitric oxide and its downstream signaling, soluble guanylate cyclase and cyclic GMP production. And this itself can contribute to diastolic dysfunction. And there's some thought that this inflammation can impair something called the unfolded protein response, mechanisms which clear dysfunctional proteins from the heart. And this made a lot of sense, and there was a lot of evidence to support it. However, a number of trials have looked at strategies to enhance nitric oxide, soluble guanylate cyclase, cyclic GMP signaling, like long-acting nitrates or phosphodiesterase type 5 inhibitors like sildenafil, or soluble guanylate cyclase stimulators like vericiguat. And none of these showed in multiple trials, actually, any benefit on exercise capacity or quality of life. And actually, in some trials, there was a trend towards harm. However, this theory really hasn't been adequately tested because no big trial of anti-inflammatory drugs has been conducted. But I think there's some thought that one will be forthcoming soon. So that's still a possibility. But I think now what's evolving is sort of the multiple pathophysiology theories, that there is no one unifying pathophysiologic mechanism, and that there's different subtypes called phenogroups where the pathophysiology and the therapy would be unique. And it may be that we may be able to identify these subtypes just by clinical characteristics. And Barry has done a lot of work on this with the obese HFpEF phenotype. So I think that's kind of where we are right now. And actually, the NIH is funding something called HeartShare, which is this big multi-center observational study, which is going to collect a lot of data on HFpEF patients and then see if we can define these therapeutically unique subgroups. So kind of more to come on that.
All right, thank you. Now, Dr. Borlaug, certain other cardiac conditions, one of them being cardiac amyloidosis, may mimic heart failure with preserved ejection fraction. And I wonder if you could say a word or two about some of these mimicking conditions.
This comes up all the time and remains something that confuses people when they talk about HFpEF. And we write a bit about this in the article. When we're using the term HFpEF, we're excluding other specific etiologies which have their own distinct pathophysiology, natural history, and treatment. You really need to, or caregivers really need to consider these individual forms other than what we call garden variety HFpEF. So these may be things like hypertrophic cardiomyopathy, which is due to genetic mutations in proteins in the sarcomere, or genes that are involved in the sarcomere. Things like constrictive pericarditis, things like high output heart failure. These are not super common, but in a HFpEF practice, they certainly do come up, and they're very important because we treat them differently. And so we really need to identify these. The one that you mentioned, cardiac amyloid, is also a very important example. This is a cause of the clinical syndrome of heart failure where the ejection fraction is frequently normal, but it's due to a different cause. This is due to accumulation of a abnormal misfolded protein in the myocardium, which makes the heart muscle extremely stiff. And we know that these patients have a different prognosis. There are different forms of cardiac amyloid. And there are important new treatments that can improve both quantity and quality of life. So it's very important. The onus is on caregivers to identify these patients and not simply treat somebody with cardiac amyloid as if they have HFpEF, because that would really do them a significant disservice.
Now, Dr. Redfield, I'd like to turn to treatment of heart failure with reduced ejection fraction. And this has been a pretty tough history, in that many therapies that may be effective for heart failure with reduced ejection fraction simply have not been effective in patients with heart failure and preserved ejection fraction. And I wonder if you could tell our listeners a bit about treatment, both pharmacological treatment and lifestyle interventions that may be effective in heart failure with preserved ejection fraction.
Sure. I think it's important to start with what does work? What do we know works? And finally, after, as you mentioned, years of negative or equivocal trials, we have a therapy that really has clearly been shown to be beneficial, and that's sodium glucose cotransporter type 2 inhibitors, or SGLT2s, such as dapagliflozin or empagliflozin. And two large trials, one with empagliflozin, one with dapagliflozin in patients with HFpEF, and a meta-analysis combining those two trials with trials of these agents in heart failure and reduced ejection fraction, show highly statistically significant benefit on the combined endpoint of heart failure hospitalizations or cardiovascular death. And that benefit was primarily driven by reduction in heart failure hospitalizations. However, pooled analysis suggests a benefit nearly statistically significant on cardiovascular death as well. And there's been some smaller studies with dapagliflozin that have shown clinically meaningful improvements in 6-minute walk distance and quality of life. So really, these two large trials, unequivocal benefit, suggest that we should use SGLT2 inhibitors in patients with HFpEF. Now, there are some important contraindications. You cannot use these in type 1 diabetes. You cannot use them in patients who have a history of ketoacidosis or who have severe impairment in renal function with a GFR less than 20 mils per minute per 1.73 meters squared. Relative contraindications, you want to think about it carefully, and shared decision making with the patient if they have a history of frequent urinary tract infections or genital infections, because these agents make you lose sugar in your urine. They're diabetes drugs, actually, and so they can increase the chance of those infections. But actually, those were slightly more common in the trials in patients receiving these agents, but not dramatically. So that's the one drug therapy other than loop diuretics, if the patients have volume overload, that are of clear benefit in HFpEF. Now, there are some non-pharmacologic strategies that have been shown to be important, and that's educating the patient in heart failure self-care, make sure they understand the importance of adherence to their medicines and any dietary restrictions or fluid restrictions that might be needed. It's important that the patients learn how to monitor their disease, their weight, vital signs, and their symptoms, and that they know who to contact and how if their condition is worsening, and that can help avoid heart failure hospitalizations. Other non-pharmacologic effective strategies include aerobic exercise training, and in patients who have HFpEF and obesity, diet-induced weight loss and exercise training can improve exercise capacity and quality of life. So those are the things that are strongly recommended. There's a few therapies that can be considered, and this is mostly because of sort of equivocal benefit in trials. The first one, this used to be our only therapy for HFpEF, was spironolactone or eplerenone, a mineralocorticoid receptor antagonist. And there was with spironolactone the TOPCAT trial, which showed a trend towards benefit on heart failure hospitalizations and CV death, but not statistically significant. Another important drug to think about is sacubitril valsartan, the angiotensin receptor and neprilysin inhibitor drug, very effective in HFrEF. But the one big trial in HFpEF that looked at heart outcomes showed a trend, but again, not statistically significant benefit on heart failure hospitalizations or CV death. One other therapy that can be considered is implanting a sensor called a CardioMEMS device. It's a pulmonary artery pressure sensor that's actually implanted in the pulmonary artery and is interrogated by the patient daily with that information transmitted to a website. So it's a type of remote heart failure monitoring. And using that to guide therapy in 2 trials suggested a reduction in heart failure hospitalization that was particularly dramatic in patients with HFpEF. Some shortcomings with the trials that prevented it from getting a very strong recommendation, but definitely something to consider if you have the resources to do this type of remote monitoring and if the patient is really at high risk for heart failure hospitalizations. And then lastly, things that you shouldn't do. We talked about nitrate, sildenafil, and vericiguat not having any benefit in trials of patients with HFpEF. So that's really what we have for HFpEF right now. There are comorbidities that must be managed, but really these are the only HFpEF specific recommendations we can give at this time.
All right. Well, thank you very much for that terrific summary of where we are in terms of treatment. And I want to thank you both very much, Dr. Redfield, Dr. Borlaug, for this very illuminating discussion, for your insightful comments about heart failure with preserved ejection fraction, which is now one of the most important causes of heart failure around the world. This JAMA author interview was produced by Shelley Steffens. The audio team here includes Daniel Morrow, Lisa Harden, Audrey Foreman, Marilyn Frickluck, Hannah Park, and Dr. Linda Brubaker. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.